Okay, we are now live. So my name is Dr. Frank Warsh. I'd like to welcome everyone who is joining us live, and certainly if you're joining us on an archive webinar, welcome, welcome. This is the first M-Talk hosted by the Medical Post. And so the goal of M-Talks is we are going to be discussing all sorts of practical issues of medicine. We're going to try and stay away from things that are sort of acute hot button topics. And the goal is to try and benefit both experienced doctors and trainees to really talk about issues that you just won't learn, or at least probably won't learn properly on the wards or from lectures in medical school. And so I'm going to say that our first topic is going to be a really joyful one for a happy spring, and that's malpractice. And joining us for this discussion is Dr. Lisa Honey. And you are out of where?
Well, I'm in Ottawa, and I'm full-time now with the CMPA as a physician advisor. My background is obstetrics and gynecology.
Okay. And we also have Dr. John Crosby, who is an expert in a large number of malpractice cases. I was going to say hopefully on a expert end and not on a receiving end. And John, where are you out of?
Cambridge, a family doctor in Cambridge.
Family doctor in Cambridge, and it's the Old Country Quack is the blog.
The Kindly Country Quack.
The Kindly Country Quack. Okay, my apologies. And Dr. Franco Rizzuti is a fourth-year preventative medicine and public health resident out of Calgary.
Yeah.
So welcome, and Franco. I don't know if you want to introduce.
Yeah, sure. Happy to. Yeah, for sure. Thanks, Frank. So yeah, as you said, my name's Franco, fourth-year public health resident in Calgary. So that keeps me busy. But the kind of other side of my dish is a lot of work within the resident and student leadership space. So both at the provincial and national level. So hopefully we can leverage some of that in our discussion today.
Great. Okay, so for the topic of malpractice, and of course, it's not something we can really explore the gamut of within 45 minutes to an hour before taking questions. But I think the first thing is we'll just go around the room and ask people, how do you define malpractice? Lisa, you're with the CMPA, so this would be most salient to you, I guess, at first.
Well, the interesting thing is, Frank, I don't like to think of it in terms of malpractice. I like to think of it in terms of good practice and practice improvement. And if we practice safe medical care, we're going to stay away from the issues related to malpractice. So it's reframing how we deal with it. And I like to think about safe medical care.
Okay, John?
Well, mal is French for bad, mal de tête, headache. So bad practice. And I agree with Lisa, we should be looking at quality care. When you're an expert, the two things that the judge and jury look at are, did the doctor fall below the standard of care? And did that failure to maintain standard of care cause harm to the patient?
Okay, and Franco?
Yeah, I think, from the trainee perspective, malpractice is the word that everybody kind of scuttles away from and, is afraid of, oh, I don't want to be that physician. But I really do like the way Lisa framed it of how do we kind of look at this in a continuous quality improvement and quality assurance way of, as trainees, how are we continuing to build our confidence and skill set, but then still providing optimum care. So I think it's, for trainees, I've tried to encourage them to think about it in the positive constructivist way compared to thinking about it as this scary thing that, we don't want to talk about.
Typically easier said than done if I'm remembering my experience on the wards, but anyway, maybe by R4, it's a little bit more humane. I guess the question and that I had thought of, we have sort of the general idea of malpractice, but then there's, of course, is the consequences of them, or at least how the physicians experience the consequence in terms of professional complaints versus actual lawsuits. Lisa, I don't know if you would have the data on this or just a general picture of how much malpractice ends up, as dealing with strictly the college versus a lawsuit. And does every lawsuit then entail a college complaint for the doctor?
So I don't have specific data for you, but I can tell you general trends are that legal cases and malpractice cases are on the decline. But what's on the increase is college complaints and hospital complaints. So we're seeing more of those. Fortunately, less of the full-blown legal cases. And it really does depend on the type of work and the specialties involved. So it's all over the map, and it's something that is likely going to touch you at some point in your career, and it's an experience that can be absolutely devastating for you as a person. But CMPA is there to walk you through it. And so if you are ever served with legal papers, the important thing is pick up the phone and call the CMPA. We'll walk you through what needs to happen. But don't wait. Don't put your head in the sand and pretend it's not happening, because there are some very time-sensitive things that need to happen once you are served. So fortunately, on the decline, but it's still a reality for all of us.
And anyone can chime in with this answer, I guess. What are the sort of common scenarios where, whether it's college or whether it's lawsuit, where malpractice arises? Not everything is going to lead to a problem. Is it communication, record keeping? Is it actual, a clinical outcome, like, for example, in your own field in obstetrics, Lisa, or that's sort of the one that's fraught with peril. On the flip side, in public health, we've one of my colleagues, when I worked in public health, he had a complaint because he didn't oppose the municipality giving permits for wind turbines or something like that, and he got dragged through a whole process for that. So what's common, what's not common? Maybe John, if you want to.
Yeah, I was an emergency doc for 20 years, and I've been a GP for 28 years, so I'm real old. And the stuff I see is the patients are usually mad at the doctor. So, if I always say that, if you're really nice, they won't sue you. And I see that in cases, like they'll say, sue the specialist, but don't sue my family doctor. I really love him and I want to keep him. And so I think that's the biggest tip I can give to the audience today is try to, and that's hard to be nice all the time, for 48 years, because you can be crabby, you can be tired, you can come off a night shift. People can be really annoying. They can be depressed and angry, and we're seeing people in pain and worry. COVID is a huge problem. Everybody's on edge right now. So you really have to suck it up and just go in there, and sometimes you might even have to fake a smile, and you really have to listen to people and nod, and body language is important. They want to be heard. The biggest thing is the doctor ignored me, he didn't listen to me, and then they're mad at you and they want to punish you. So don't let them get mad at you.
Franco, your thoughts on that and what you've seen?
Yeah, I mean, I would echo what John said. I think a lot of it, from what I've seen and what you hear about, it comes down to communication with the patient. And if you can, communicate well with the patient and they feel that they've been heard, even if it's bad news or a tough situation, communication is a big piece. I think a smaller one is really the record keeping in challenging situations. And that's one where I know as trainees, we sometimes struggle of, it was a bad outcome or things didn't quite go as planned. How do we make sure we document it in a way that, can protect you 3, 4, 5 years down the road? Because sometimes that's how long it takes. In public health, it's really interesting. As you said, Frank, it's, we sometimes get these odd places and complaints that come in because the MOH didn't oppose a policy or didn't stand strongly enough. But I mean, I think MOHs and some of us who are salaried in that space are in a little bit different kettle of fish because we're stuck with organizational policies. So I think, that's the other space, is if you're breaching policy and good standards of care. But if I was going to circle back, I think the big ones are really communication and rapport with the patient.
And I concur with all of that. That's certainly what we see in our CMPA files. Communication just weaves through all of them. And the idea that the patients have unmet expectations, and knowing what those expectations are is so critical to our ability to care for these patients. Other themes that we see, we break it into provider, team, and systems issues. And unfortunately, the systems issues are underrepresented in our CMPA data. But when it comes to provider issues, there are things like, as Franco mentioned, documentation and situational awareness and diagnostic reasoning and diagnostic error. So those are all things that play into what seems to drive the complaints and the lawsuits. In addition, it's the team function, the collaborative care models, and the teams not functioning as well as they could in situations that go sideways.
So would that be, for example, you have a situation or a complaint or even a lawsuit that arises from one member of the team against the other, or from the patient that is sort of they're ill at ease with whatever's happened and it's the dynamic that's the problem?
No, for the most part with teams, it's the idea that we don't work in isolation, especially in hospitals. We rely on the nursing staff. We rely on the, in my case, the midwifery staff and the family docs and the specialists working together. So it's that closed loop communication that needs to happen within that team, and the concept of team situational awareness, and how do we empower people to speak up in those teams if they see things that are needing to be addressed, but they're worried about the hierarchy. Mm. So it's all that it's all tied into how that team functions.
Sorry, Franco, were you about to chime in with something?
No, go for it.
Okay. So I guess getting into a little bit of the nitty-gritty here, with records, what tends to be the most common scenario or complaint related to record keeping?
If I can answer that, please, Frank. I worked for the College of Physicians and Surgeons of Ontario as a supervisor, and that means that the doctor, if they get a lot of complaints, they have to pay me out of their own wallet to come and help them, avoid that in the future. So they really pay attention because it's really expensive. And I recently had a doctor with 20 complaints in 1 year. Like, I've had one complaint in 48 years. I've been sued once in 48 years, which were both devastating. And luckily I was exonerated, but this guy had 20 complaints in a year. And it all comes down to charting too. I find every single of the 7 doctors that I supervised have been terrible charters. And I used to be a terrible charter. So I'm like a reformed hooker here, preaching the gospel. And because I used to go really fast and emerge, and I do a happy face with a couple of stitches in it and stuff like that. So I flunked a peer review in my nursing home. So I had to get religion and start to learn how to chart a lot better. And you have to use the SOAP method, subjective, objective, assessment, plan. You have to show your thinking. You can't just use little tick boxes. You have to, it doesn't have to be an opus or anything like that. You can do this quickly, but you have to write down the pertinent complaint, the pertinent physical findings, and then your assessment. You don't just go migraine, or, if the guy's got a headache, you go headache, query, tension, migraine, rule out subarachnoid, rule out meningitis. So if this guy ends up with a subarachnoid hemorrhage, the judge will see, even if you missed it, the judge will see you were thinking about it. and then plan. You do, you know, send to emerge immediately or get a CAT scan stat, get to a neurologist. So it really gets into charting. And that's all. When the case finally gets to court, it can be 10 years later. And they know, like the judge and the other lawyer, you know, the prosecuting lawyer, and if there's a jury trial, they know you don't remember anything. I mean, we see 30 people a day. So that's thousands of people. So they know you don't have a clue about what you remember with that patient.
Sure.
So it's all in the chart. If you didn't write it, you didn't do it.
Now, here's a question, and Franco, I'd be curious. So I'm, you know, John, you would have been in the generation that taught me. So that was the docs where, whether it was a merger, even in the office, it was all hieroglyphics and little sort of symbols and acronyms. I'm sandwiched where I taught, you know, Franco's generation, but of course you guys are now completely electronic. You know, those of us from my years, we sort of grudgingly accepted electronic records, but I'm curious as to whether they have, you know, they're a real pain time-wise, but how have they changed the picture with regards to complaints, malpractice? Oh, John, that's for you to answer.
No, my secretary's leaving for an early weekend.
Okay.
Oh,
All right. Yeah, because this is one of the major changes that I'm curious about in the way medicine is practiced and whether it manifests in the, you know, the medical legal system as well, and how.
yeah. I mean, I agree with you. I think the transition to electronic medical records has been both good and bad. I think it's allowed us to, you know, have central repositories, have more information on hand. But, you know, I can speak from experience as Alberta is still transitioning fully from paper records to electronic. It creates this dual chart issue where you're now figuring out, where do I chart? What is the, you know, the source of truth, which is a challenge. But I actually think the biggest challenge is copying errors forward. And so it's really easy in an electronic chart to just go back to yesterday's, you know, internal med consult and SOAP note and look through that and pull a lot of the history forward, maybe validate some of it. But if there's an error in there, it can sometimes be really easy to start copying that error forward inadvertently, because 3 or 4 other people have had that same error that they've copied. And so I do think that the electronic space has created new challenges for us, especially in just having to be hyper vigilant and diligent in our charting, and also like working on being concise. It's really easy to be verbose and write these long electronic documents and have templates. So I think it's really going back to chart what you did, chart your thinking, capture that. But I think it's a little bit harder to see and kind of finesse the art of it in the electronic space.
Are we seeing from the CMPA, Lisa, any sort of the new world or new world order, whatever the cliche is?
Well, I appreciate Franco's comments. What we do see in as far as documentation goes, one of the biggest issues is incomplete assessments. And the issue with electronic medical records is the idea of cut and paste, and that cutting and pasting templates is fast and easy, but you are not necessarily capturing what you did for that specific patient. So when using electronic health records, you need to be very careful about templates and tick boxes, and try to use the free text if you can to elaborate your thinking, to write down your differential diagnosis, because the medical record is your way to communicate to the next person that's going to see that patient what's going on and your thought process, as Franco alluded to.
Anyone else want to add something there, just as a...
I just wanted to show you, this is a recipe card. This is the chart of the doctor before me when I started, 28 years ago. So that's where it's come from. and it's just got the patient's name, what they're allergic to, and what drug they were on. So we have come a long way. And,
I like the
yeah,
coffee. Is the coffee stain his or
Yeah.
yours?
that's actually old Scotch tape stain.
Oh, okay.
There, it was so
Oh.
old, Scotch tape died. But yeah, and just to reiterate what Dr. Honey said as well, is you can't just use a template. Now we do use templates because we use the Rourke baby scale for babies. And
Sure.
Dr. Honey knows we use the antenatal scales. I know there's one in Ontario, and I'm guessing there's probably one in every province. So we do use templates all the time. I mean, we have ACLS and ATLS. Those are templates. And the depression score for the Hamilton depression score. But you can't just sort of go tick box, yes, no, yes, no. The template is just a prompt for you to be more thorough. So when it's the Rourke baby and it says, what's the baby doing at 6 months, you've got to type in there, sitting alone, one tooth, that kind of stuff. It's just prompting you. So the doctors that get into trouble, it's just all tick boxes and cut and paste. And we can tell when we come in and look at that, as from the college standpoint, it just screams at you. You can just see the doctor has done that. So you have to show what your thought, what are you assess? Even like with blood pressure, you have to say good blood pressure control or poor blood pressure control. So plan is to cut down salt, exercise, diet, double their Norvasc, that sort of stuff. You don't have to write a whole book, but just show what you're doing. So if something goes wrong and that patient has a stroke and complains about you or sues you, you can say, I'm doing everything for a stroke, Your Honor. Blood pressure was great. He was on aspirin. There's nothing else you can do for a stroke. We've checked their echo of their heart, checked their carotids. So I've done everything possible to prevent a stroke. Sometimes people just have strokes. I mean,
Sure.
so you're going to be found innocent at that trial, or they will usually, settle before that. But if you just have a crappy chart that's your scrawled handwriting that just goes BP 150 over 100, see me in a month, you're in big trouble. There's no way they're going to defend you for that, because that's not the standard of care. The standard of care of a reasonable, normal, average doctor is to address all the risk factors. You don't have to be Einstein, just a regular, normal doctor that's prudent. You're not held to a really high standard. You're an average standard.
Now, one of the things that came up, because you'd mentioned it, John, a few minutes ago, is you gave an example of a person that's, a doctor sort of sees a patient with a common complaint, whether it's headache, back pain, and we all sort of do the query when we're asking things that it could be. Now, here's a question. Are you then on the hook for, if you've entertained this diagnosis and it's sort of, we all have things that we'll write on a differential that are, of course, very low on the probability scale, but having put it on a record, are you then on the hook for, if something goes wrong and you've missed it, or, we see, you said you were thinking about a subarachnoid, did you refer them to the eMERGE for an urgent CT and a lumbar puncture? Do situations like that arise, I guess, first of all, and are you liable in that circumstance?
Yeah, I was an expert in a case just like that. A guy went to eMERGE with a headache, was sent home, just tension headache, came to his family doctor's office. So these true emergencies can walk into your office too, or limp into your office. Like people can come into your office with an MI and chest pain or a stroke. We all see them because, a lot of them say, oh, I'm going to wait 6 hours in eMERGE. I can see you faster, doc. So with this case, this guy, was missed, and the doctor was found guilty for missing the subarachnoid hemorrhage. Like he should have sent the patient back up to eMERGE for a stat CAT scan. And that's tunnel thinking. When someone comes in and your secretary types tension headache or migraine, she's making the diagnosis. The patient's making the diagnosis. You should make the diagnosis. Like we used to always tell our clerks in eMERGE, and I tell my secretary, just tell me what the patient says. I've got a headache, I've got a sore arm. Don't make the diagnosis. Don't say patient's got a migraine. Because as soon as you write migraine, your brain is thinking down migraine. And people with migraines can have subarachnoids. They can have meningitis. So you've got to back up and say, just describe the problem and then do your differential diagnosis. And if it's one of the differential diagnoses is an emergency, like if the guy comes in with indigestion and you write rule out MI, the only treatment of ruling out an MI is to go to emerge immediately. I mean, if they're having an MI, you got to deal with it right away. It's better to overdiagnose the MI and say, oh, sorry, it was just gas and just gastritis and GERD, than the opposite way around, like, whoops. So you want to rule out the bad stuff first.
That's a great point, John. And I think that the important thing is rule out the bad stuff first, because when you write out your differential, you've got to say, you know, am I possible? But then in your narrative, you know, I don't think so because of X, Y, and Z. And then, you know, move on to your less serious diagnoses, but always be thinking of the ones that are serious.
Mm-hmm. Yeah, and for Dr. Honey too, abdominal pain in women, anybody, and I've seen a number of ectopics, and they can be so subtle, and I'm sure she'll agree with me. You know, if you've been in the business long enough, you're going to get burned by them, because they can come in with just very subtle abdominal pain. Any woman of childbearing age, you know, and they might not have missed a period. I once had a woman come in Emerge, and she just had this vague abdominal pain, and I was just getting ready to send her home. And the nurse said, oh, now the pain's on her shoulder tip. And I went, oops, you know, we better call gynae. So, you know, thank God we were slow to get her out of there. And she'd ruptured her ectopic, and her blood pressure went to 0 and scared the hell out of all of us. Everything turned out fine. But, you know, some of these things can be very subtle, and you really have to have a high index of suspicion. And one thing I warn all primary care doctors, and you know, I've worked as a walk-in doctor, I've worked as an emerge doc, a GP, you know, I've worked as a hospitalist. Always get help from a specialist if you're not sure about things. You know, if you see somebody with weight loss and you can't figure it out, history, physical lab, don't just say, I don't know what's wrong with you. You know, send them to an internist. Make sure you're not missing an occult cancer there. Same with a fever of unknown origin. Same with fatigue. Like, don't just, like, we have specialist backups and we need to use them more. That's a big problem I see. I had this one woman once, she had a breast lump during pregnancy, and the doctor said, oh, I'm not going to do a mammogram because I don't want to get radiation. So he just sat on her until she had the baby, and then he sent her to a surgeon, and she had breast cancer and died of it. She died of the breast cancer during the trial, you know, a few years later. It was so horrific and terrible for her and her family and the doctors and everybody. I mean, it was just, and all that doctor had to do was refer her to a surgeon as soon as he felt the breast lump. Like, he didn't even have to do a mammogram or anything. Like, so, and he was found guilty. There was no way to support him. He had, you know, so it was so easy. And same with moles and stuff. If you have a weird looking mole, don't be a hero. Get a dermatologist to biopsy it. I'm always guessing wrong on skin cancers. After 48 years, I cannot eyeball a skin lesion and tell you what it is without a biopsy. So cover your rear end as much as you can. That's kept me out of a lot of trouble.
Now, Franco, we haven't heard from you in a while. What's your sense of this? I mean, again, you're still in training, and I imagine the experience on the wards, which I would think is behind you now, but it's still got to be fresh in your mind. How are you know, doctors being trained to understand this, to approach it?
Yeah, that's a great question, Frank. I think I think it's a place where there's definitely room for improvement. I mean, we're all going to have our own style on how we, you know, chart, how we, you know, make sure we're not missing the worrisome issues. But I think it's a place where, you know, there's potential right now, right, for a competent trainee to be fairly independent and see a lot and not really have that time to debrief or talk through or get another perspective. So whenever I'm with a junior, I always encourage them for here, let me come in and see what you're doing. Let me see, how you're going through this. We can talk through it just so I can get a sense of their thinking. And it's something that I try to ask for as much feedback as I can. And I think that's always my encouragement to trainees is this is the time to ask for feedback, to be in a safe space to make a mistake and have somebody there that can debrief with you. And so I think it's a place that I'm really excited with Competence by Design, and the fact that the CFPC has moved to the Triple C. I think it really allows for more hands-on observation and more of these point in time. Actually, you know what? Try to do this a little bit differently. So I think I'm excited about what the future holds. I think COVID has really pushed us, and I do worry about kind of the trauma and the PTSD this generation is going to have of trainees, because it's just been such a different learning environment. So I think that's going to be a challenge we have to face in the next little while. But I think overall, I'm excited with Competence by Design and more assessment to help guide and kind of nurture the younger generation.
John, you had something to add?
I totally agree with you. I think that's really well put. One last thing I forgot to say about charting is always under plan at the end, always have follow-up on every single patient, even if they come in with, a sunburn or a paper cut or a hangnail, get in the habit, develop good habits while you're young. We put on seatbelts whenever we get in a car, we brush our teeth in the morning when we wake up, we get into habits. So under every time I write, under plan, I'll always say, call if worse, go to emerge if worse. And that can save you so much trouble, because someone can come in with a simple cold, this is pre-COVID, but it's just a simple cold and turns into, meningococcal meningitis in 6 hours and kills them. Like, it can happen that fast. And they present with a URI. So you're covered. If you write in there, neck was supple, kid was afebrile, and I just always under plan, call or go to emerge, if not better, and see me within a week. So, and that's just every one of my charts for no matter what patients have, that's just automatic at the bottom. And I always remember an old family doctor in Oakville, as old as me, back when I was a young emerge doc, said, you just always write FU, FD on every chart. And he says, I thought you were swearing at me for all those years, but you were just saying follow up family doctor. No, not FU family doctor.
Now I'm going to use that though as a pivot point, because we were also talking about one of the other major issues is patient expectations, as well as, and to a lesser extent, system expectations. We all worked emerge and said, well, go follow up with your family doctor, or, we were writing our charts, follow up if need be in 1 week. Well, doctors only have so many hours in a day, or you have somebody that is coming in with, they pre-diagnosed themselves and pre-prescribed themselves, or even worse, they borrowed a pill from their mom or their sister's medicine cabinet, and boy, this worked like a charm. Tips on how to handle those unmeetable expectations. So whether it's, what do you mean you can't see me within a week? Why can't you give me the 5 Percocet? Because I really feel great when I take them. I guess, again, we'll go around. So Lisa, get your take on that first.
Well, actually, I'm curious to hear what John has to say about that one.
Okay. Well, Franco first.
Here's a specialist that's referring to a GP. So you can go both ways. And that's brilliant. And you should do that. And so the secret is take my time management course. It's free. And I offer free mentorships by phone. And you can get my free ebook at drjohncrosby@rogers.com. And so then you can see people on time and you don't have to wait a week. It is tough. And I had a patient like that. I had a guy, a whole bunch of risk factors for opioid abuse. He loved his booze. He hated his job. He smoked like a chimney. And he came in with a sore knee. And he said, one of my buddies at work gave me this Percocet. It's fabulous. It cured me. He's way better than you are, doc, with your Advil and your Tylenol and your physio. And so this does happen to us. It happened to me. And I had to sit down and say to him, you are really high risk for opioid abuse. And, you know, if I give you this stuff, you're going to be hooked on it and you're going to be a chronic pain patient forever. Like, let's work on it with Advil. Let's work on it with physio, stuff like that. So that's one of the toughest things of all, you know, saying no to inappropriate opioids. And they complain to the college about you. The doctor didn't treat my pain adequately. And then they complain to the college about you because you use too many opioids. And a lot of the people, and I'm sure Dr. Honey will agree with me here, a lot of the doctors that get in trouble with opioids, it's because of poor charting. You know, you look at their chart and it just goes Percocet, 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 month after month after month after month, 100, 100, 100, 100. You're in trouble. You're in big trouble with the college there, because they go, where's the control? Who's examining this patient? So every time they come in, you have to examine them. You know, even if they've had back pain for 40 years and you've seen them 4,000 times, every single time you have to get them up and flex and extend and check them out. And how are you doing? And can we taper these narcotics? And then you're not going to be in trouble then. Like, the college is not mad that you're prescribing opioids. It's mad if you're not controlling them and trying to taper them, try other things. Have you sent them to a pain clinic, even though it takes 2 years to see it? Are you trying here? Not just Percocet, Percocet, Percocet.
Now, Franco, how do you train, or how were you trained in meeting possibly inappropriate expectations, whether it's for follow-up, whether it's, I think I need an MRI for my sore elbow, or, you know, and they clearly just have a tennis elbow.
I mean, so I think, as I reflect back to how I was trained, I think it's always going back to, you know, patient might come in and say, I want an MRI. And your job as the one examining, either as a trainee or as a physician, is to say, okay, let's pull it back a bit. What's going on? Like, what's happening? What are your thoughts around this? What are your expectations? And, you know, I've gotten into the habit that I will ask a patient early on, what's your expectation out of this? And to get a sense, because if they're telling me their expectation out of coming to emerge and waiting the last 6 hours is they just want an x-ray, well, then I kind of can think of a game and plan. And if we're not going to do that, then I know that that needs to be part of my communication back to them. So I think it's really asking the patient. One of the challenges I've seen in public health, and I think this is similar for a lot of specialists, is we are getting third, fourth, fifth hand consults. And we get a lot of information that has been refined and distilled as we go through. And, you know, whenever something doesn't quite line up, when I get an urgent care or emerge consult and the patient's, you know, 20 feet away, I say, can you just put the patient on the phone and let me talk to them for 5 minutes and hear what they're going through? And so I think it's really going back to, what's the patient's expectations? What are their thoughts on it? And again, it circles back to that communication and building rapport with the patient. And I think we're pretty good with that. I think the challenge is as we get more senior and trainees, I think some of that gets beaten out of us as we try to be more efficient, or we get corrupted by the system. But I think early on, trainees are pretty good at building that patient rapport and understanding what the expectations are.
That's good news, because I wasn't back when I was a trainee. But anyway, that story from the Stone Age. Lisa, anything to add?
I was just going to say, I love, Franco, your use of Fife, and I think it's something that that's not done as much as it could be. And the other thing is, choosing wisely really helps to give us some vocabulary around what are best practices for this particular complaint, and addressing the expectations that may not be met in that patient encounter, but the explanations as to why you're doing what you're doing, and why you're practicing safe medical care.
So before we get to some questions that were sent to us, one of the things that I had written down, one of two things. So the first is, you know, in the same way that EMRs have changed the sort of malpractice medical legal milieu, we've had major demographic changes in the profession over the last 20 years. You know, about half or even more than half of new doctors are now women, and that goes back to when I was in med school 20 years ago. And likewise, we have a much more diverse practicing healthcare community. Are there any changes in terms of whether it's complaints, lawsuits, communication errors, things that you're seeing, any of you, due to just the simple demographics? And it's not to assign blame, it's just to sort of, where are we at with things?
I'll jump in and I'll take a slightly different approach. I think what we're starting to see a lot more of is advocacy from physicians around systems issues. And physicians now are willing to say, there is, systemic racism here, or there are challenges with getting the patients the supports I need. And so I think, internal to the profession and to the system, we're starting to see a lot more advocacy and speaking up around things earlier. So I'm optimistic about that. I think the challenge is then how do leaders and how does the system quickly respond to that, especially with all the other pressures. So I'm optimistic about that, but I defer to Dr. Honey and Dr. Crosby as to kind of what we're seeing from the college and CNPA perspective.
I haven't seen any any sort of trends in gender or race or anything like that personally.
And I would concur. I think that our newer generation is very interested in work-life balance and working very hard toward that. And gone are the days where you do a 24-hour call and then go to the operating room the next day. And I'll include myself in the younger generation. We like the idea that we know our limits, and that we know that I have a certain capacity for fatigue, and after which I am not acting in the best interest of my patient. So I think it sort of behooves all of us to know what is your limit, and if you've reached your limit, you need to reach out for help or rebook that procedure and do the right thing for the patient.
Yeah, I totally agree. And, as the older generation, and I lived with those people, we had a chief of surgery that said we were on call 1 and 2. And he said, the only thing bad about 1 and 2 is you're missing half the cases. So he wanted us to work 24/7, 365. And we were called interns because we were interned in the hospital, and residents, you were a resident of the hospital. So I come from that horrible work-life imbalance, and I always hated that, and I always led the charge away from that. We went on strike in 1973 to be on call less often, at great peril to ourselves. And I got a call system here in Cambridge 30 years ago where we're only on call 1 night a month, and that's really good. And that helps with malpractice and college complaints, because if you're exhausted after being on call all weekend or all night, you're going to snap at that patient. If something goes wrong, they can sue you or complain to the college about you. So you have to come into the job well rested, and you can do that. There's ways to do it. It's, once again, I'm happy to help you out for free to do all this stuff. I'm more than happy to share it.
Okay. And finally, before we get to questions, I've been in the situation, I don't know, Franco, you probably haven't. John, I suspect you have, but you're in the middle of a day, whether it's your office or Emerge, there are 20 people that are waiting to see you. And in the mail comes a couriered letter from the college, or maybe a process server comes in and talks to your secretary. You get handed this thing, and there's no way it's not going to affect your mental state, your emotional state. I guess tips on how to handle that. Oh my God, I'm, up this creek without a paddle, at least for the next few hours. Pearls of wisdom for people stuck in those shoes.
Yeah, well, that happened to me. I was after a night shift in Emerge, a 14-hour night shift, not good medicine. I got sued over a woman that stuck a mascara brush in her eye, and it ended up with a corneal transplant, Pseudomonas ulcer. Yeah, you just feel like you've been punched in the stomach. I ran up to medical records to read thank God I charted properly, and it had a happy ending 2 years later, but it was horrible. And that's, I have a lot of empathy for people who go through that. So never alter the chart. Number one, do not, if you don't, you can't go back and retype the computer, because they have forensic computer experts that can tell if you've done that. And if you do it by handwriting, they have handwriting experts. So never, ever alter the chart. Call the CMPA immediately and keep your mouth shut. Don't talk to anyone else except the CMPA, and then they will tell you what to do. That's my advice to you.
And that's my advice as well, is take a deep breath, stay calm. Sometimes the language in these statements of claim and these college complaints make you sound like the worst doctor that ever walked the earth. And it is like a punch in the stomach. And so stay calm. This is going to happen to most of us at some point in our career. We're not bad doctors. And call the CMPA. We will help you. We will walk you through what's next. And if you don't argue with the process server, they're just the courier. They're just dropping off the paperwork. There's no point in not accepting it or trying to avoid it. The other thing I would caution you about, though, is the medical record. If it's a hospital patient, you are not the custodian of that medical record. The hospital is, and you need permission to access that medical record because it's not for direct patient care. So again, before you go to the medical record, your best bet, just call the CMPA and get some advice about what to do next. It will be one of a number of conversations you will likely have with them, but we'll walk you through it. And it doesn't mean you're a bad doctor. It doesn't mean you need another career. It's something that you will get through, and we'll work with you.
Okay. Franco, anything to add?
The only thing I'm going to add, and this is probably more targeted to my generation, is to stay off social media when these things happen. In that, I know a lot of my colleagues, we will share a lot of things on social media, but this is one of these things that this is not the time for social media. This is the time to, as folks have said, take a deep breath. If you aren't in the headspace to continue with your day, you're better off to cancel or see if other patient or physicians in the office can see. Take the time you need, talk to the CMPA, but yeah, please stay off of social media.
So you don't tweet the content of your complaint letter, or not? Yeah, I got off Twitter a year and a half ago or so, and I have not looked back. But that's a discussion for another day. And actually, this just came to me before, because a few of the questions are actually quite similar to each other. The role of the apology when you know you've made a mistake, or even when you've actually wronged a patient. What do you guys all think about that? Does it help? Can it come back to bite you?
I'm happy to take that one, Frank. The issue around apology is often what patients want to hear, and you should generally consider it. It's the human thing to do. And when you apologize, it doesn't mean that you apologize and accept all the blame. It's okay to say, I'm really sorry this has happened to you. And, you don't need to fall on your sword and say, I'm so sorry I did this to you. It's important that you have all the facts. And in fact, in Canada now, there is apology legislation in all provinces and territories except Yukon and Quebec that actually protect you from that apology being brought up again in a court of law as an admission of guilt. So it generally is a good idea to apologize and be human and be empathetic to the situation the patient finds themselves in.
An apology law has got to be the most Canadian piece of legislation ever devised. And on that note, things that were brought up sort of by multiple commentators. They all revolve around, of course, the changes in practice since COVID-19 came in. That, so much of medicine switched to virtual care. So this is sort of a 2 or 3 part. The first is factually what effect has the increase in virtual care had on complaints, malpractice concerns, et cetera. And the second thing is, of course, how do we handle this? What are ways to avoid the pitfalls? Because of course, with virtual care, you don't have physical exams. You are way more at risk for people falling through the cracks through system errors or whatnot. And no matter what, I mean, we're actually doing really well here, but I find that when you get on a Zoom or a Skype call, there's an awful lot of yelling, and the normal tone that we take in a conversation is lost. So yeah, I just like to sort of get everybody's input on that. John, if you want to start.
Yeah, I'm sure Lisa will agree with me. It's always standard of care. So when things go to court or you're sued, they ask another doctor who's a peer, a person just like you. So if you're in Cambridge, they don't get somebody from Toronto to come and comment on you. They get somebody from a similar sized city as you in a similar practice. So it's a peer thing. What would an average, routine, normal doctor do? And so, say somebody phoned you and they had abdominal pain and you did it all virtually over the phone or with Skype, and they ended up, being harmed by an ectopic or an appendix or something like that. So you have to do a proper history, and then you go, geez, I can't do a physical here, and I can't rule these bad things out. So once again, you're going to have to punt them to emerge. And I know my emergency colleagues will hate my guts, but when I was an emerge doc, I would never resent a doctor. The only time I resented doctors dumping an emerge is, like some chronic problem that they'd never even tried to do. But I was always more than happy to see anything that was acute like that. So, and then document.
Franco, any changes you've seen?
A lot. I mean, I think the big changes, and it goes back to how we train and how we support, is right. You can take a great history, you can build rapport, but it is really hard to train some of these key skills. And I think, that's one of the challenges is our preceptors are not used to how do we train in a virtual environment? How do I, in some situations, the resident or medical student isn't even in the same physical location as their preceptor. And so now you're having 3-way Zoom calls, or they're jumping in. And so there's the learning the technology, there's learning the systems. I think virtual is going to be here to stay. I think a lot of patients like the convenience. And so I think, again, this is one of these things on this 5-year horizon that the profession is really going to have to think about. How do we address standards of practice for this and make sure that we have good supporting guidance for trainees and staff to do virtual care safely, and what's appropriate for virtual care? I think that's the big thing that we're really starting to learn with COVID is what's appropriate for virtual, what isn't. And my last comment with COVID is it goes back to the charting, is I think there's a big system push to standardization, to drop down menus, to tick boxes, because it's easier to export the data and use for public reporting. They don't like free text. It's hard to extract data out of. And so I think we are in a little bit of a tension with what the system wants of we need to just continue doing what's appropriate, standard of practice and good patient care, appropriate charting. But I think we're going to keep seeing system pressure to try to drive us more to easier pre-fillable forms and things like that, because it's easier for the data folks.
Yeah, no, I mean, I can just add that this was a problem 10 years ago where, you're working at a community health center or something and they bring in a much worse EMR because the bureaucrats like it. And, it ends up being a nightmare, and it takes 5 years to get the system changed. But anyway, sorry. Lisa, did you have a
Yeah, just a
thought about
couple of
virtual care?
comments about virtual care. I think the virtual care, I agree. I think it's here to stay, and I think it's played a huge role in our ability to keep things moving during COVID to help with patients' access. One of the things that is important is there needs to be consent to perform virtual care. The patients need to understand the limits of virtual care, and that if you tell them right up front, we may not be able to address all these issues over the phone, and we may have to rebook a time for you to come in where I can do an exam. And the other big issue is privacy, and both privacy of information, so the risk of using an unsecured platform like Skype that's not encoded and encrypted. But there's also the privacy that happens with, as you said, people on Zoom calls talk really loud. I'm talking really loud right now, but to know who's listening to me and who's overhearing this conversation that I'm having with my doctor, and know who's in the room with them that may be off screen or off the telephone that's listening in, and to document that as well. So there's certainly a lot of issues to consider with virtual care, and but used properly, I think it's a tool that really is helping facilitate patients get the care that they need.
Now, are those conversations going on between, I imagine, between sort of CMPA, academia, maybe academia, but certainly the colleges around some sort of setting of these standards? Because eventually if this is what we're going to do, then, there has to be a system to support it and protect both patients, but certainly the profession
Yeah.
from problems that arise.
The CMA has the virtual care handbook that I think is a really useful resource. That's not provincial. It's a national. And I know each college is going to have their own issues that they want to make sure that they address. But from an oversight, I think the CMA document is a good one.
Good. Anyone have anything else they want to add? I see by the clock on the wall we're getting close to 4. So, okay, we've been at it for about an hour. So I want to thank our panelists, Dr. John Crosby in Cambridge, Dr. Franco Rizzuti in Calgary, and Dr. Lisa Honey in Ottawa for joining us for the very first M Talk on malpractice. I'd like to thank all of our viewers that sent in live questions, and hopefully we will get to see everyone out here sometime in the future. And thanks again for the Medical Posts for hosting this. And everyone have a safe and happy weekend.
Thank you.
Bye-bye.